Good. Good evening, everyone, and welcome to today's session. We are going to start in a bit, by 7:15. Feel welcome and ready to learn.
Mercy, you kindly mute everyone. Mercy. Mercy.
Hello.
You kindly mute everybody. Mute everybody. There's a lot of noise. Hello, Mercy. Hello, Mercy.
Hello.
Mute everyone, including. Can you mute?
Yes. Yes, I've muted everyone.
Oh, sorry, thanks.
Okay. I think we can start by 7:15. We allow some to join since we just delayed a bit when starting the meeting. Good evening again. I'm Mercy Kiptele, the SRHR coordinator for Barrier Breakers Youth Initiative. We are going to start our session today. Our speaker is ready, Mr. Donald. So you can start off as we wait for others to join. You can go on as they join later, or as they join, we continue. If you have any question, you can chat in on the chat box. Since I have muted everyone, there was a lot of noise and we couldn't cooperate. So I think it's better if I mute everyone and then you can chat in your questions. And then in case you have to ask a question, you can raise your hand up and then I will unmute you. Thank you. Welcome, Mr. Joshua. Mr. Donald, sorry.
Okay, so hi, how are you? I hope I'm clear.
You are clear.
Nice, thank you. So thank you very much, and I'm glad to be here once again for this the second cohort. I was there in the training for the first cohort, and we had quite an amazing experience with them. I'm getting some feedback. So somebody unmute. Okay, thank you. Now, as I was saying, we had some nice experience with the initial cohort, and it serves me quite an honor to be here again, just to discuss with us a few things about foundations of maternal health. So my name is Nas Donald Galula Manas. I had graduated from Moi University. Later on, I worked at Kenyatta National Hospital as a nursing officer intern. I moved to USAID, working for their program called Management Sciences for Health as a technical advisor. Then I worked for Washington State University, my recent job, where I worked as a research assistant. Right now, I serve as the national chairperson for Kenya Students and Novice Nurses, which is also a partner in implementing this project. So again, I understand we've got people from different backgrounds in this program. And so in my presentation, I've tried as much as I could not to be too technical, but come up with a presentation that can be easily understood by everyone. So I'm trying to share my presentation. Let me check. Okay, nice. Okay, good. I hope my presentation is visible from your end.
Yeah, it's visible.
Thank you. Thank you, Mercy. Now we'll go direct to it. Dear friends, when you're talking about foundations of maternal and child health care, what are we talking about? Basically, this is, we are trying to answer the question, why this program? Why is it important for that this program is there? So once we get to understand the why part, then we are able to answer the other technical parts of the program, that is the what. So this is we are doing the why. I understand you began with some bits of the what. The way the mode of the content delivery is the how, through Zoom sessions, and the when already it's already happening. So we want to understand the why part of maternal health and child health care, so that when you are saying you want to build a cohort of youths who are knowledgeable about maternal health and champions for child health, they have got the requisite knowledge and gain the requisite attitude to be able to enable them do what? to enable them handle basic issues concerning maternal health. Now, let's begin with some operational terms, which is basically the definition. So we are saying maternal health and child health care. It refers to a package of comprehensive. One of the keywords here that I want you to note is the word comprehensive. Comprehensive healthcare services, which are developed to meet, number one, a promotive, to meet the preventive, to meet curative and rehabilitative needs, pregnant women and children. And when you're talking about pregnant women, this should be between time of conception or when you've conceived, and when a woman delivers a child. So, and the health of the child from delivery, that is from 0 days up to preschool years. So children are regarded to be from 0 years of age up to 5 years of age. So again, like I said, it is the health service. It refers to the health services provided to mothers, those are women in childbearing age and children. So I want to pause here and ask a question. Who are women in child that we consider? What is the range for reproductive age? Any guesswork? You can equally type it in if you're not able to unmute yourself.
I have enabled everyone to unmute themselves so they can unmute and then talk.
Okay. Nani anaweza kutuambia what is the range of the reproductive health for women? Any guesswork? Because we don't have a right answer, no wrong answer. Okay. I think somebody has said 18 to 45 years. That's a good, it's a good guesswork. Thank you. From 10 years, that is Alice. Yes, and anybody else? 12 years. So thank you. Generally, reproductive ages are it's a range from 15 years to 49 years. Again, I said it's a range. So we find cases where you've got a 13-year-old girl getting pregnant. I think the most extreme one was 9 years old. The one I've heard of was a 9-year-old girl getting pregnant. So the range will be between the range that is considered is between 15 years to 49 years. Unless it has changed. I think now we can now mute our mics. So meaning if you're talking about a reproductive age of 15, okay, thank you. So if you're talking about a reproductive age of from 15 years or 12 years to some extent at another time, 9 years, then it means that even adolescents do what? They deserve to receive what? Reproductive health services. So these are, and reproductive health services can range all the way from family planning, sexual reproductive health education, all that package, a comprehensive package of reproductive health, because they are in their reproductive age. Of course, we live in a society whereby we want to believe that when children are young, let's say young adolescents, knowing less about reproductive health or sexual reproductive health is a sign of innocence, of which it has always worked against us when we now find out a 12-year-old girl is pregnant and parents don't know what to do. And now they have to do what? They can't seek maternal health services. They have to use other means to hide the pregnancy. And this has always worked to the detriment of the young girls who end up getting pregnant. So we are saying that everybody, health is a fundamental right, and so is reproductive health services, and so are maternal and child healthcare services. Now, moving on, what are the objectives of maternal and child healthcare? Remember, we are trying to answer the question, why? Why do we need this program? Why do we need to learn to build a healthy and a mother-child? So the objectives of MCH are, number one, to reduce maternal mortality and morbidity. We'll be able to define these terms later. To reduce perinatal and neonatal mortality and morbidity. We also want to regulate fertility so as to have wanted and healthy children when desired. Remember, family planning is part of the package of MCH. We also want to provide basic maternal and child health care to all mothers and all children, and to promote health of mothers, and also to promote and protect physical growth and psychosocial development of children. You'll be able to look at how these ones can be achieved. Now, like I said earlier, MCH has got three main components. And number one is maternal health. We have child health and family planning. If you read other literature say differently, but I'll want you to use this approach, because other literature want to talk about education and about psychosocial support, but all those things you can do them. Under maternal health, we have the things you do under in maternal health. In child health, there are things you do under child health, including education and psychosocial support. The same thing with family planning. But today we will not discuss family planning, because there is a session on family planning. Now, as we try to understand these, we'd like us to look at some vital statistics that inform us. Remember, at the back of your mind, you should have the question, why? Why maternal and child health? Why is it important? If you have that at the back of your mind, you will sail through this session very well. Now, there are things which are called maternal indicators or neonatal and newborn indicators. Those are the vital statistics. So vital statistics are the ones which inform decisions that are going to be made by the government and caregivers concerning maternal health programs. So if, let's say, before Linda Mama came, there was data that informed what? Linda Mama. If you go to Kakamega, there is Oparanya Care. I hope it's still there. So all these things have to be informed by data. And the data in maternal health are what we call the maternal indicators, or newborn indicators. Now, which indicators are these ones? Number one, there's something called maternal death. And we are saying a maternal death is a death of a pregnant woman within 42 days. It's a death, the death of a pregnant woman, or a mother dying within 42 days after termination of pregnancy. So if you get a mother dying during pregnancy or after pregnancy up to 6 weeks, and the causes of the death must be related to the pregnancy, or it must be due to factors that are aggravated by pregnancy. So if, let's say, the mother became ill, the illness should have been aggravated by pregnancy or caused pregnancy. If a pregnant mother dies from a road accident, that data cannot be entered as a maternal death. It will go into the other statistics. I think that is a crude death or something. There are other indicators that we see in defining population. Then we have late maternal death. A late maternal death is a death of a woman from direct or indirect obstetric causes, occurring more than 42 days, but less than 1 year after termination of pregnancy. 42 days, that is 6 weeks. When you're talking about termination of pregnancy, the word termination of pregnancy means either the mother gave birth or she miscarried, either of the two. Either it was birth or a miscarriage, so long as we've lost, the mother is no longer pregnant. So that's what we mean when we say termination of pregnancy. Next, we have maternal mortality rate or maternal mortality ratio. This is the number of maternal deaths per 1,000 live births. Again, note the term live births. So the number of maternal deaths per 100,000 live births in the same period. Usually it's during a period of 1 year. And then now, what is a live birth? A live birth is a complete expulsion or extraction from each mother of a product of conception, irrespective of the duration of the pregnancy, which, after such a separation, the product of conception, it shows evidence of life, either through breathing or pulsation of an umbilical cord or muscular movements. So just to explain this one, we're saying a live birth is either wakati mama either amejifungua mtoto mwenye yuko alive and kuna evidence ya life, ama we can have a miscarriage or an abortion, but in that abortion we expand a live product of conception. And products of conception, that involves the fetus, the placenta, anything that wasn't in the uterus before in the pregnancy test that comes out, and it should be complete. So that is what is referred to as a live birth. I hope that is clear. And then now we have maternal morbidity. Maternal morbidity, this is any symptom or condition resulting from or made worse by pregnancy. An example could be what? Hypertension in pregnancy. Or we also have other conditions like eclampsia. It's a condition resulting from pregnancy. And if maybe the mother already has hypertension, then the pregnancy makes the hypertension worse, it becomes a morbidity. So any condition that is resulting from pregnancy or it's made worse by pregnancy, it's a morbidity. And now there's another term, severe maternal morbidity or a near miss. So a near miss, it refers to a woman who almost died, nearly miss. You see, like in an accident, God forbid, you are walking on the road, then gari kuje, it could brush off. It nearly hit you, but it didn't hit you. So you nearly, the vehicle nearly missed you, right? So that example, when you have a severe maternal morbidity or a near miss, it's a woman who almost died, but survived the complication that occurred either during pregnancy or during childbirth or within 6 weeks after the termination of pregnancy. Remember, I'm not saying after birth, after termination of pregnancy, because pregnancy can be terminated either through birth or an abortion or a miscarriage. We together. And the reason why the mother survives, it's because of the medical, the care she receives from caregivers. So for example, you deliver a mother, if you're a nurse or a midwife, you deliver, a mother is delivered, then she goes into hypovolemic shock or hemorrhagic shock because she has lost a lot of blood. Now she has gone into shock. This is a mother that if you don't take care, you're going to lose that mother very fast. So if you put in intervention and this mother survives, she adds the statistics of a near miss. Now, we have other indicators for children or newborns. But first of all, I want us to define the term a neonate. So a neonate is a newborn baby in the first 4 weeks of life after birth. So kumaanisha neonate hawezi kuwa older than 4 weeks, meaning we cannot have a 24-year-old neonate. Ama namna gani? So a neonate up to 4 weeks. Now, what's neonatal death? Neonatal death is the death of a newborn in the first 28 days. And then you have an early neonatal death and a late neonatal death. So an early neonatal death will occur in the first 7 days of birth. A late neonatal death will occur between 7 and 28 days of birth. And then now we have perinatal deaths. So perinatal deaths, these are stillbirths and the number of neonatal deaths occurring in the first week of life. The first week of life per 1,000 live births. Again, look at these operational terms. It is the number of stillbirths, meaning a child who is born already dead, number of children born already dead, plus what? The number of children, the number of early neonatal deaths per 1,000 live births. Then we have neonatal mortality rates. This is the number of neonates dying before reaching 28 days of age per 1,000 live births in a given year. So which is the most important indicators that you must, if you decide to forget everything, if you decide to forget everything, do not forget neonatal mortality rates. Do not forget maternal mortality rates. Those are most important indicators that are used in informing data. Now, how does Kenya look like in terms of mortality rate and newborn mortality? Remember, again, I'll repeat, remember we are asking ourselves the question, why? Why should we look at maternal and child health care? Now, look at these reports that I've been able to post here. This is from the Kenya Demographic and Health Survey, which is usually done after should be 9 or 10 years. Now, significantly, the maternal mortality rates in the year 2003 in Kenya, we had 414 deaths per 100,000. In 2008, 2009, between this period, 2003 up to 2008, the rate was 488, meaning it increased, but it significantly reduced towards 2014. In 2017, it reduced to 342. In 2020, what happened? I'll leave it as an assignment for you. Go find out what was the mortality rate in 2020. And if you can get 2021, the better. I left out 2020 because the number was higher in 2020 than in 2017. I think you may all know why in 2020 the number was high because of the issues with COVID. Many mothers were giving birth from home. This is the year when we had a high number of teenage pregnancies, and teenage pregnancy is a risk factor for maternal mortality. Let us look at newborn mortality rate. In 2003, we had 33. In 2018, 2019, 2008, 2009, we had 31. So it has been gradually reducing over the years. But somehow in 2020, according to UNICEF and World Bank, it increased back to 33. Again, we ask our questions, why? What happened? What was so special with 2020? You can go find out what happened in 2017. Again, I left this one and left this one. So find out and try to check how that graph has been, how Kenya has been behaving. So that if you look very carefully right now, people are doing a lot of sexual reproductive health programs and education to the youths. All these things have been informed by data. I believe this project also came up as a result of what was happening in 2020. So we use data to inform decision. We use data to inform policy. Like we have a new policy, a new guidelines, the reproductive health guidelines. I think it's 2 weeks ago from the Ministry of Health. If you like reading policy papers and guidelines, you can look at it and see what the ministry is doing to do what in managing in terms of reproductive health. Most of the ministry papers are still quoting the 2017, the data from 2017. So it's usually very difficult to get the most recent data, because checking it from UNICEF, from World Bank, most that data sites, some data platform haven't yet updated. Now, how does Kenya compare to the world and in East Africa and Africa as a whole? This is from UNICEF. This is the data showing maternal mortality rates from the year 2000 up to 2017, and it's showing how different countries are behaving. Now, if you look at this, is this what is called royal blue? Should be royal blue or sky royal blue. So countries which have been painted royal blue have got a very low mortality rate, and those are most countries in US and in Europe. You can check what Europe has been doing. The only countries in Africa which have recorded less than 100 are Egypt, Libya. Which country is this? Okay. So we have these countries in North Africa. The North African countries are scoring better than West Africa and Eastern Africa. Again, when you go to the South, they are performing better. Now, let us come to Africa. Okay. In Africa, what is happening, especially here in Kenya? So in Kenya, we are marked amber. Is it amber or orange? This is amber, right? And for amber, that is... Yes, Nancy. Thank you. So Kenya is still ranked as a country which is experiencing a high mortality rate that is between 300 to 499. And it's the same case as Uganda and the same case as Ethiopia. Looking at the Democratic Republic of Congo, the same case. Tanzania are performing poorer than us. Look at them here. It's theirs is between 599. Somehow in East Africa, the countries which are performing best is Rwanda. If you can see Rwanda here, they have a sky blue. Rwanda is somewhere, this is Rwanda. They have a sky blue. So Rwanda, then Kenya, followed by Uganda, then the rest of the East African countries follow. So Kenya is also among countries doing better if you rank them in the entire of Africa. But can we do better? Yes, we can do better comparing what we are seeing happening in other parts of the world. So that's why it's very important that we are able to build a community that is well versed on issues of maternal health. I will leave it to go and look at how the maps look like in terms of neonatal deaths or the neonatal mortality. And now, what do you think are the causes of neonatal mortality? We are going to look at the causes of maternal mortality, but again, another assignment, you go find out the causes of neonatal mortality. Let's look at maternal mortality. Now, maternal mortality, there are 3 levels of causes of maternal mortality. We have direct causes, we have indirect causes, and then we have the delay causes. The direct causes, there are 5 major direct causes. And the number 1 cause is postpartum or hemorrhage, or let me just say hemorrhage. So these direct causes are causes resulting directly from obstetric complications of pregnancy, labor, and puerperium, and from interventions or any other effects of these events. So things like the mother bleeding after birth or during birth or before birth. What are the other direct causes? Okay, we'll look at them shortly. Then the indirect causes, these are causes resulting from a previously existing disease or diseases that developed during pregnancy, which was not due to direct obstetric cause. So for example, things like malaria, things like HIV, anemia develops during pregnancy, then it kills the mother, or maybe diabetes developing during a mother who is diabetic. So any cause which did not was not caused directly by the pregnancy, but from an existing condition, heart conditions. And then now we have the 3 delays. We have either the mother delayed to do what? To seek appropriate care. And that can be because of cultural reasons. Let's say, for example, a 13-year-old girl is pregnant. Now, because of shame, parents don't want her to go for the clinic. What will happen? They'll delay the process of seeking care. Most people delay up to the time when the pregnancy has really advanced. Or maybe this child develops complications during the process of pregnancy. She has a threatened abortion, but you delay taking the child to the facility due to family reasons, socio-cultural reasons. Then we have a delay in reaching appropriate healthcare facility. Maybe it can be due to lack of means of transport. It can be geographical issues. The hospital is far. You can't reach on time. Next, we have delay in receiving adequate emergency care at a facility. You've reached a referral hospital. People are busy. Nobody is paying attention to you. You develop complications, and we lose the mother. So anything arising from these delays can cause what? A maternal death. So like I said again, we have direct causes, and the leading cause of direct causes is hemorrhage. We have indirect causes, malaria, then we have the 3 delays. Let us look at some infographics here. Look at this photo. Now, we are saying 1 in every 300 Kenyan women die while giving birth. That is from data received up to around 2015. This is quite a big number, right? And then look at the ranking of Kenya. That Kenya was ranked number 21 as the worst countries in which to be a mother. Yani tumerank huko 21. This is a very bad indicator. Now let us look at these causes of maternal deaths. If you look at this graph, we have direct causes and indirect causes. So the direct causes are these ones, from hemorrhage here, going all the way up to obstructive labor. So this part this part of these pie charts. And like I said, a quarter of maternal deaths caused by hemorrhage. It can be hemorrhage during pregnancy, during birth, or after birth. The next leading cause is sepsis. But from other data, it has ranked unsafe abortion. So we have sepsis, hypertension disorders. We have an unsafe abortion contributing to 13% and obstructed labor. Now, this is where we have some point of concern, especially us being Kenya and our culture. We are saying unsafe abortions are causing 13% of maternal deaths. Then, is it appropriate if we advocate for sexual reproductive health, rights, and education? My answer is yes. So what do we do in order to curb what? Hemorrhage. These are things which are done in the hospital. What do we do in order to curb sepsis? Again, this one is more of the therapeutic intervention. What do we do to curb hypertensive disorders? This is purely management all through pregnancy, management of hypertension. What do we do to curb, to reduce obstructed deaths occurring from obstructed labor? Again, it's joint work between the midwife and the mother, but majorly the midwife. But now what do we do for unsafe abortion? And now the question is this one: where is unsafe abortion occurring? Are they occurring in the hospitals? No. Meaning most of the unsafe abortions, and remember this is from the reported data, meaning we still have more happening that which is not being reported. So we need as a society to embrace a way in which you're going to handle unsafe abortion. Either is to provide an avenue for provision of safe abortion care and promote safe abortion care. Remember, I'm using the word safe abortion care, appropriate safe abortion care. And also trying to implement and advocate for timely, age-appropriate sexual reproductive health and rights education. Maybe if we do that, it will be able to do what? To reduce whatever we are seeing here. Because I will charge you to go and look at data. What is the age bracket of mothers who are dying from unsafe abortion? Try to tabulate the age, all the way from 9 years up to 49 years. Which age is most affected? Now, we have other direct causes causing 7%, and now the indirect causes like malaria, anemia, HIV, AIDS, causing the rest of the 20%. This data, it depends with the source you are getting it from. Of course, these values may change, but one thing that will be very consistent is hemorrhage. It will, most of it, from every data you will go, you'll find it's nearly a quarter, if not a quarter. The same thing with unsafe abortion and sepsis. These direct causes, you'll always find them. 5. 1, 2, 3, 4, 5. Now, Kenya has got some targets that it has set. We are saying that we are trying to reach a point where we'll only have 100 deaths per year, to reduce from these figures we are having from 342 that where we were in 2017, and I think in 2020 it was 370 something. We want to reduce them to 100. That is our target as a country. Can we reach there? Yes, we can. Now let us move on to another dimension of this presentation. Now we looked at the causes of maternal death. Now, do we have risk factors that may contribute to maternal death? Now, maternal risks are defined as maternal risk is a probability of dying or experiencing a serious injury as a result of pregnancy or childbirth. What are these risks? Number one risk of a complicated pregnancy will be a young primie or a primigravida. Primigravida refers to a first-time pregnancy or a first-time pregnant mother. Primigravida, it's a first-time pregnant mother. So if you have a young primigravida getting pregnant at an early age, below 19 years, this is a mother who is at risk of developing complications. Why? Their anatomy is not yet well developed to handle pregnancy. The uterus and other reproductive structures have not fully matured to handle pregnancy, because remember, pregnancy is a stressful physiological change. Stressful to mean physiologically stressing. The body needs to be adequately prepared. The second one is an elderly primigravida. That is, if a woman delays getting pregnant from age of 30 years and above. At times you find a mother who is 40 years getting pregnant. Remember, I'm saying primigravida. Your first pregnancy is at 30 years and above. You are at risk of developing what? Complications later in pregnancy. Would you want to find why? Why is it that delaying getting your first pregnancy might predispose you to risks? Why do you think so? Anybody? Does anybody has a kuna mtu akona guesswork? Or let me pick on somebody, let's say Michelle Anyango. Do you think, what do you think happens when that predisposes one to risks? Okay. Nobody is talking. Sawa. Let's move on. The other risk is having too many babies. That is, when a mother bears more than 3 babies, she's at risk of that is called either you are carrying too many babies at the same time, or you've given birth. Umezaa watoto wengi, multiparity. Multiparity, that is, umekuwa pregnant for a higher number of times, or you have multiple pregnancies, maybe twins, or you have triplets or quadruplets. Why? If you get pregnant, if you have a high number of pregnancy, your tissues, the tissue begins wearing out or weakening. You're having poor physical health, and these are some of the things that weigh the mother down. I'm looking at the chat box, and Michelle is asking, pardon, please. Okay, I'd asked, why do you think getting the first pregnancy after or being elderly, let's say from 30 years and above, why do you think getting first pregnancy from 30 years and above may predispose one to risks, or the pregnancy to risk? That was the question. If you can type it in, the better. Let us look at another risk. Poor spacing. So when the interval between 2 pregnancies is at less than at least 3 years, it can create problems during the next pregnancy. It's because the mother did not get enough time to recover completely and fully from the stress and strain of the previous pregnancy. So if you are there in the community and you meet a mother alikuwa pregnant, then after 1 year uko pale kwa facility, you meet the mother again, pregnant again after 1 year. I think you've seen these cases, especially in the villages. The mother is pregnant today, she comes, she delivers. 1 year later, you meet her almost pregnant again. and the cycle continues. So usually, again, sometimes it can be due to cultural reasons, it can be due to socio-cultural reason, level of education, church, religious issues. There are some religions which don't believe in family planning. There are some religions which don't believe in, some culture we don't believe in giving the mother space to breathe. And by doing that one, the mother is predisposed to risks or complications of pregnancy. That is when now education comes in and family planning comes in the community. So if you're in the community and you meet such a case, try to figure out what is the best, how would you best approach this situation? How do you best approach the mother to do what? To take up family planning. I remember there was a time I was in Kakamega and there was this mother, we had gone for a chief's baraza. Kuna mama kuna watoto wengi. I think by then she was pregnant again and she had 9 children and she was still young, around 27 or 28 years. That's somebody quite young. She has 9 children and she's in her 10th pregnancy. She was forced by the community kupelekwa facility yenye tulikuwa for her to be started on to be advised on family planning. And the next thing that they were advising her to do was to do a TL, a tubal ligation, because now it was becoming unbearable. Remember, you want these children who are going to be born to have optimal health. So if a mother is getting pregnant every now and then, even the children who are being born are not getting enough time to breastfeed. Now, other causes, other risk factors are maternal conditions. Which are these maternal conditions? Okay, now this is where it gets interesting. A mother who is short, less than 145 centimeters, may have a small or an inadequate pelvis. Sijasema to profile watu wafupi, lakini being shorter than 145 centimeters might be a risk because of anatomy. The same thing also there, being too tall is usually also another risk because tall people have got a certain type of pelvis that may not also be adequate. Weight, mothers who have less than 40 kgs of weight usually are malnourished. They tend to become anemic, therefore have a high risk of developing complications during pregnancy. That is why in preconception care, you want to advise the mother to do what? To gain weight fast. Remember again, a low weight, being underweight is also a risk factor it's a cause of infertility. So you find somebody is really trying to get pregnant, but weight yake ni kidogo sana. So usually begin by looking at such things. Now, mothers who are having more than 70 kgs of weight may also have difficulty during childbirth. As I've been a midwife and I've seen these ones. At times, a mother who is quite heavy, wanakuanga na a lot of problems during childbirth because of the maneuvers that you want to do. We also have mothers who have malnutrition and anemia, just like I've said in the bullets. We have got other risk factors or associated medical conditions like heart diseases, rheumatic heart disease, high blood pressure, kidney disease, TB, diabetes, repeated attacks of malaria. And this one, repeated attacks of malaria is one of the high risks in Kenya, especially in Western, Nyanza, and Coast region. And we also have hepatic disorders. Other conditions like, okay, fine. We may have other infections like cytomegalovirus. Now let's move on. From the next slide, I'll be moving a little bit fast. Do we have any question up to that point? Millicent Tunashanga, do you have any question up to that point? I hope we are learning. You can type just in the chat box to say, yeah, we are learning, it's interesting, or anything to encourage me now that we are all muted. Now, we said maternal and child health care has got 3 components. We have maternal health care, we have the child health care, and we have family planning. Now, can we look at maternal health care? Okay, as before we look at maternal health care, I want to answer what Teresa is asking. What do you mean by appropriate health facility? So I'll take us back to that slide when we were discussing about the 3 Ds, the 3 delays. Delay in reaching an appropriate health facility. An appropriate health facility, let me use an example. Tuko kwa health center. Kwa hii health center, a mother develops complications. She needs to be referred to a higher level facility, maybe for cesarean section, because cesarean section cannot be done in a health center. Now, this mother delays reaching to that health, to that facility of referral. Maybe hospital in an ambulance. Maybe they don't have funds. They don't have a means of.
Ngalula, you're muted. I can't hear you.
I'm sorry, I guess we muted it while you mute. Now we are saying the mother needs specialized care, which is not being provided in the current facility. Due to reasons of logistics, transport, or any other reason, the mother anacheleweshwa kufika wapi kufikishwa kwa hiyo facility. You've heard of cases like the other day, it was in Kitui, where the parent was a man was complaining he lost his wife and the child because walikuwa kwa health center, wakakuwa referred. Baada ya kuwa referred, ambulance wanasema haina mafuta and all those things. By the time wanafika kwa facility ambayo walikuwa wamekuwa referred, it was too late. The mother died and the child died. So that's what you are talking about, delay in reaching an appropriate healthcare facility. I hope that is well answered.
Yes, thank you.
You're welcome. Let's move on. If there hakuna swali lingine arising from the previous part. Now we are saying there are 3 components of maternal health. We have got antenatal care, we have intranatal care or natal care, and we have postnatal care. So maternal health, this is the care given to a woman during pregnancy, during childbirth, and after childbirth. It is also a care, sometimes it's also given to a childless couple when they're trying to get pregnant. That is preconception care. Now, there are 3 components of maternal care, which is antenatal. Antenatal care, this is care given to a mother from the time of conception, when conception is confirmed, when a mother is confirmed to be pregnant, immediately the mother is confirmed to be pregnant, care should begin from there, up to the time when she has delivered. Up to the time when she's going to deliver. Then we have intranatal care. This is the care given to a mother from the beginning of labor up to the time when she delivers. Postnatal care is the care given to the mother and the baby from the time delivery is complete up to 6 weeks post delivery, post expulsion of products of conception. let's look at antenatal care. Now here we'll go first, because most of the things are technical, which are done in the health facility by caregivers. Now, antenatal care is the care given to a woman from time of conception, when conception is confirmed, until the onset of labor. And their objectives: what do you want to do during antenatal care? What do you think a mother should be seeking during antenatal care? So that if you are in the community and you are advising a mother, umepata the mother is pregnant, 5 months pregnant, hajawahi enda wapi? Clinic. Now you want to advise this mother, mwambie, now it's important for you to go to clinic. Why is it important for her to begin clinics for antenatal care? These are the objectives. The reason why we do antenatal care is to promote, protect, and maintain the health of the mother during pregnancy, because pregnancy is a high risk period for mothers. Number two, we want to ensure that we have a birth of a mature and a healthy baby. We also want to identify any high-risk mothers and give them appropriate attention to prevent complication. Usually they are seen at a different level of facility. They're attended to at the high-risk clinic. Then you also want to prepare the mother for confinement, that is through labor and delivery. And lastly, you want to do what? You want to prepare the mother to care for her baby. You're preparing the mother for motherhood and parenthood. Now, as a blanket, we usually talk about antenatal care. But some time back, WHO adopted something different. It's called focused antenatal care. And in Kenya, it was adopted in 2012. So antenatal care as it is, it's blankets. It's like a tent. But for focused antenatal care, it's more individualized and more focused to specific objectives that are going to be achieved on specific times. Now, what is focused antenatal care then? So focused antenatal care refers to a minimum number of 4 comprehensive and personalized antenatal visits, each of which has a specific items of client assessment, education, and care to ensure prevention or early detection of complications and management of complications. So it is personalized and comprehensive. You look at each mother as a single unit. You have to develop an individualized plan for every client or every mother coming to the facility. And these are the objectives, the same thing as I've pointed out. Now, we are saying, what are the activities which are done during ANC, during antenatal care? In my discussion, I have discussed the blanket, the blanket part of antenatal care, generally what is done during antenatal care. But for those ones who are more interested in learning on antenatal care, I'll send you a material after the presentation so that you're able to see what exactly happens during the first visit, what exactly happens during the second, the third, and lastly, the fourth visit that the mother goes to for clinics. Now, this is the schedule for what? This is the schedule for antenatal visits that a mother should adhere to. In the first trimester, the mother should be able to go to attend our first clinic within the first 8 to 12 weeks. That is when we make the first contact with the mother. In the second trimester, the second visit is scheduled between 24 weeks up to 26 weeks. In the third trimester, we have 2 more visits between 32 weeks and between 36 to 38 weeks. All these ones have been categorized depending on how the baby is developing. Remember, in the first 12 weeks, you cannot hear the heartbeat of the baby. You cannot feel the parts. You cannot feel hakuna bado baby. Baby bump. You cannot feel the gravid. But now that one you can it imeanza kuonekana during the second trimester. That is when you try to listen to the heartbeat of the baby. You try to check where the fundal height is and all that. So if you read the document I'll send you on focused antenatal care, you'll do what? You'll be able to check you'll be able to check on what happens exactly on every visit. So what we are using in Kenya, we are using focused antenatal care, that model of the focused antenatal care, which says that you should attend a minimum of 4 clinic visits, but you can go up to 8, because remember we have this 1, 2, 3, 4, 5, 6, 7, 8. So WHO advises that mothers should attend clinic up to 8 times. But ikiwa haitawezekana ye attend at least attend 8 times, the mother should at least attend 4 clinic visits, at least 4 clinic visits. So what does that mean? That means that clinics should be begun as early as possible. Immediately a mother confirms she's pregnant, clinics should be begun. Okay. Now, what happens during antenatal care? Again, in my discussion, it's general, but the document I'll send you, it's specific on visit 1, visit 2, visit 3, visit 4, visit 5, up to 8, or the 4 visits. Now, the first thing that usually happens and include her in the data that the government collects. If it's in Kenya, you want to register her for Linda Mama, sindio? If it's in other counties like Kakamega, they were registered to Oparanya Care, where when the mother is pregnant, unakuwa registered kwa hiyo platform. So hiyo platform imekuwa generated na maana that itakuwa na kutumia SMS when your next visit your clinic is due. Then when the mother delivers, the county government through Oparanya Care buys her what? It gives her some cash, inamnunulia some gifts for the baby, clothes, some shopping. I'm not sure if it's still there. It was there some few years back. I think they adopted it from Obamacare. Now, like we said, ideally the mother should attend the antenatal clinic once a month during the first seven months, and twice a month during the second, and twice a month during the second, and thereafter once a week, if everything is okay. But if we have a high-risk mother, their schedule is usually different. During the first contact, we'll do the midwife that will meet at the facility will do a comprehensive history of the mother. We'll do a physical examination. We'll do a general medical examination. We'll do an obstetric examination. Laboratory lab works will be done, including blood works, urine, examining the mother for VDR syphilis, and screening her for cervical cancer, as it's a policy in Kenya. Then the other thing that will be done, that is done during antenatal care visit, is immunization against tetanus. So usually we have 2 doses of tetanus toxoid are given. The first dose is given at 16 to 20 weeks, and the next dose is given at 20 to 24 weeks of pregnancy. The second dose is usually given 4 weeks after the first dose. The third dose is given 6 months after the second dose. So most of the time you'll find in Kenya, the third dose is given in the next pregnancy, because most mothers come to health centers late. So utakuta umempatia the first dose lini, let's say umempatia the first dose at 5 months. The second dose umpatie at 6 months of pregnancy. The next dose you should get after 6 months. After 6 months atakuwa shajifungua. So that means when she will next be pregnant, that is when she'll get the third dose, like that, the fourth up to the last one, the fifth dose. Then we have iron and folic acid supplements, which are given to prevent anemia and also to help the baby grow, to help the baby grow properly. Especially folic acid, it helps the baby to the neural system to develop properly. Children who miss folic acid are at a risk of developing what we call neural deficits. Neural deficits, some of them are like a spina bifida. You've seen a baby developing with a head with no brain inside. So they are usually due to deficiency of folic acid. And other things which are done include health education. What are the right messages that are given for health education? About diet, the mother is told how to eat a well-balanced diet, personal hygiene during pregnancy, danger signs during pregnancy, during labor, and after birth. And some of these danger signs I've listed them here, like unusual pain, bleeding from the vagina, because a pregnant mother should not bleed. So if she's bleeding, it's a sign that something is wrong. Swelling of the feet and puffiness of the face, severe headache, having a blood vision, dizziness, high fever, and when you feel the baby is not moving. So during antenatal care, the mother should be taught danger signs zake yeye mwenyewe when she's pregnant. What are these signs? When she sees, she should report. Danger signs when she's having labor, which are these danger signs she should be looking out for. After she has given birth, what are the danger signs on her part and the danger signs on the baby? So it's not done after delivery, it's done during antenatal care. Advise the mother about drinking and smoking. So you advise her to avoid smoking and drinking. You've heard of what alcohol baby syndrome or alcoholic baby syndrome, and the baby is born from mothers who consume a lot of alcohol. The mother is advised on drugs. She should not just take drugs over the counter. She should always get drugs prescribed. About radiation, educate the mother about she should avoid abdominal X-rays because it predisposes the child to cancers. What do you think about sexual activities during pregnancy? Which advice would you give a mother about sex? Anybody? What do you tell, is sex contraindicated during pregnancy? Do you tell the mother, no, you should not have sex during pregnancy? Yes, Veronica? I'm not sure if we got you clearly. Maybe can somebody else can also make a try? Veronica, if you are back, maybe you can try again.
The mother should remain with one sexual partner until the partner.
Okay. So generally, sex is not contraindicated in pregnancy.
You are muted.
so as I was saying, generally, sex is not sexual intercourse is not contraindicated during pregnancy, unless unless the mother is in a condition when in a state that she cannot have sex. So sex is encouraged until a point when it can happen. Remember again, sex at the end of the at the late stage of the third trimester, sex can cause labor, can induce labor. So unless you really want to induce early labor, you can do sex. The mother can do sex at the late stage of pregnancy. But sex is not contraindicated. They just need to learn on how to do it in a manner that the mother is kept comfortable, maintain one partner so as to avoid introducing infections that may end up affecting the baby, like syphilis, okay? And towards the end of the pregnancy, again, that is when at least they can tone down on sex, unless it's being prescribed to do what? To induce labor. About traveling, especially during the first trimester and the last trimester, if the mother cannot avoid traveling, then she can reduce her traveling. We want the mother to be in a state where she is well rested. You want the mother to be in a state whereby she has access to everything she needs in case of an emergency. Now, let's move on. Protection from infections. An expectant mother should be instructed to protect herself from risk of infections, especially syphilis that may cause spontaneous abortion, malformation, mental retardation, stillbirths. Others can cause blindness. A mother can give birth to a blind child. Then we have she is educated on childcare. The mother should be educated on various aspects of childcare. Mama, wakati utajifungua, mtoto atakuwa hivi na hivi. This is what you do. This is how you breastfeed. This is how you wipe your baby during that time. In your first weeks of after umedeliver, unaweza kuwa unakosa usingizi sana, utakuwa unaamka usiku kwenda kujisaidia mara mingi. Don't worry, it's normal. See those things. And then lastly, advise the mother on follow-up visits. The follow-up visit that after she has delivered, she will still need to do what? To go to the postnatal clinic. We look at it, it's called targeted postnatal care. Eunice, you've raised your hand. You have a question or a concern?
Yes, I have a question.
Yes, Eunice.
There is this notion whereby you are told if you have sex till the end of pregnancy, you will give birth to a dirty baby. Let me say so. What do you say about that?
What do I say about that? What do you think?
I don't know.
Now, let us, that's a myth, eh? Because when people say dirty, what do we mean by dirty? Because when you may say, let me say dirty, right? It's purely a myth. Whenever we say them for Keisha, I think it's Alice. Okay. So, I was saying, no, that's a myth, really. You can't get a dirty baby because of having sex during pregnancy. So long as the mother is comfortable, sex is encouraged until when it is unbearable. I hope that is clear. There are other myths that could be there. I'm not sure of the other myths. But one that I also want to decipher here, like I was saying, the mother should be educated on childcare, and this should also include an individualized birth plan, as we are going to see. an individualized birth plan here. That includes trying to tell the mother, when you will be coming to deliver, carry clothes for the baby, carry this and this, carry sweater, warm clothing, you will need a baby shower. If you go to Western, I'm sorry to say I'm from Western. So if you go to Western, you'll find that mothers, when they are pregnant, they don't buy clothes until when they deliver. That is when they buy clothes. The reason they have is that unajua mtu hawezi fanya nini, huwezi jua ni nini umebeba mpaka siku yenye utajifungua, ukuwe sure umebeba nini ndio ununue nguo. So it's a cultural issue that is in Western. I was shocked to find it in Nairobi the other day. In January, I was doing some community. I was in the community and I met one in Korogosho. So I was trying to interrogate the mother. Hey, ma'am, naona uko namna hii. Umejipangaje kwa ajili ya kujifungua? Nguo za mtoto ziko ready? Because she was almost due. Bado sijanunua nguo, ninangoja mpaka siku nitajifungua. You get that? So, it is a myth that is there in the community, which you as a caregiver or somebody who is enlightened, you should be able to do what? To advise the mothers in a manner, but again, you advise them in a culturally acceptable way. Remember, the practice of medicine and healthcare also respects culture. I think that is where memes zilitokea ambazo mnasikianga wana nini nazo nurses. Ati huyu alikuja na kuzaa mtoto bila nguo, anataka tumfunge na gazeti. I don't know if that is where those things came from, but somehow there are mothers who do that. Now, we are still talking about antenatal activities of antenatal care. You are preparing the mother is being prepared for confinement. Confinement, that is generally labor. So the preparation for self-delivery is very important. It should be done well in advance to avoid any type of difficulty or emergency which may occur at the time of delivery. This includes telling the mother what she will go through during labor. Wakati utakuwa na labor, especially during the last trimester, you will feel pain. That pain itakuwa on this part of the body and even towards the back. At that time, what you will do in order to manage the pain, maybe you will squat, maybe you should be lying on your left, you should be doing those maneuvers. And if it is possible, demonstrate to the mother and let the mother demonstrate understanding. Ya kwamba yes, umeniambia kutakuwa na squat, aje na squat hivi. Let the mother show so as to approve ya kwamba she has comprehended whatever she's being taught. This will help so much so that during labor, she just have to be reminded. You remember during clinic, uliambiwa aje, utakuwa unafanya hivi. Ukisikia tumbo ina contract, what do you do? Wakati contractions zimeisha, pumua, breathe in, taking air so that the baby to get enough oxygen. Now, you also have psychological preparation of the mother, because remember, pregnancy is not a normal thing that happens daily. The mother needs to be really psychologically prepared for what is going to happen during pregnancy and during birth and after birth. Another activity that is done, like I said, the individualized birth plan. So what are the components of individualized birth plan? What do you include, or what do you tell the mother? Try to check, does she have a facility enye amechagua kunini ku give birth hapo? Does she have an identified person mwenye atakuja na yeye wakikuja wapi kujifungua? Does she have a means of transport for that day? Has she already planned in advance? What about the partner? If in case she has a partner, where is the partner coming in? Next, does she have all the requirements that the baby will need after delivery? That is the clothes, baby shower, and all those things. Next, family planning. Talk to the mother about family planning again during antenatal care, because women, pregnant mothers are more receptive to family planning, messages of family planning, when they are pregnant than when they're not pregnant. Why? Whatever she's going through will motivate her. Ya kwamba mimi venye nasikia baada ya huyu Miss Party, you've seen for those ones who have been nurses before, ama wenye wamewahi kuwa nurses ama wamewahi ku deliver, sometimes ukienda ku deliver utasikia mama anakuambia mimi kuanzia leo sipati mimba tena. Huyu ni wa mwisho, huyu sitaki tena mimba. So why? Because of what she's going through. But funny enough, after 2 years, she'll still get pregnant again and come back. Kulienda aje? So it happens. Now, during pregnancy is the best time to advise the mother about family planning. In Moi Teaching and Referral Hospital, women are usually advised about the coil IUCD. And if she accepts kwamba yeye baada ya kuzaa atawekewa IUCD, there is a sticker way inawekwa kwa kitabu ya clinic, so that after she has delivered, if I'm the midwife delivering her, I'll just look at the sticker. Oh, she was talked to about family planning, and she said she's going to take this method, an IUCD. So immediately after delivery, I will insert what? An IUCD, so that we begin family planning immediately after delivery. I don't know the policy of other hospitals, but that is what happens in MTRH. Again, you manage any pre-existing conditions and medical conditions. Lastly, very important, Pmtct, prevention of mother to child transmission. This one is very important, especially when we have a mother who is HIV positive. So for mothers who are HIV positive, you will initiate Pmtct. The mother will be initiated on antiretrovirals. The mother should be educated on the antiretrovirals that the baby will need immediately after delivery, so that wakati mama anakuja kujifungua, wakati anajua yeye she is HIV positive, already amebeba nini, wanakuanga na hizo drugs already. They come with them, wanakuwa ashapewa during clinic, nakwambia wakati mtoto amejifungua, hii ndio dawa yake. Tuko pamoja mpaka hapo? Now, again, women who are HIV positive at times, they may be seen at the high risk clinic because they will need very close monitoring. The same thing happens during delivery. They may want to be closely monitored so as to prevent cross transmission. Up to that point, do we have a question? I see it's what time is it? We have around 22 minutes to go. Should be done in the next 20 minutes. Again, I'm just checking at the chat box so that thank you. I'm seeing some of the questions are being responded to about sex. Thank you, Teresa. Okay. So, Anne, is that what happens to those mothers whom they've always had babies? I think there's a question I saw first, that what happens if the mother comes to the facility, ndiye amekuja tu hiyo siku na akona labor pains, hajawahi enda clinic. What happens? So you handle the mother as she has come. What are the needs? What does she need right now? Number one, she's in labor. So you are attending to the needs that are there at the moment. At the moment the mother is in labor, she wants to deliver. That is what we will do first. Then after the delivery, that's when we will do other things which should be done during including that she'll only get she'll get the TT. What else will she get? Will she get it's called what? Hii jina inapotea. Dawa ya malaria. There is an it's called oh my god, sorry, it's escaping my mind, but kuna dawa ambazo huwa wanapewa za prevent nini malaria, but that one is given to pregnant mother. So for this one, that is not her need at that time. So you handle what the current needs of the mother. The same thing, if the mother comes to a clinic at 7 months, handle the mother as she has come, do what can be done at that time. What cannot be done, cannot be done. But remember, the goal is to ensure the mother is in optimal health, the baby is in optimal health, the fetus attains optimal health. Okay. What happens to those mothers who don't have real babies? Like, okay, the head is not human. Well. I've never met a mother mwenye amezaa mtoto mwenye kichwa si ya human being, unless I think you are referring to conditions like anencephaly, microcephaly, whereby it's a birth defect resulting from or a malformation that has resulted during pregnancy. So let's say like a microcephaly. Microcephaly is a small, maybe has got a very small brain and also a small head. Sometimes it can be caused by mosquitoes or what is called there's this virus, which is most common, Zika virus in Brazil. It affects the babies. They have a small brain and a very small head. Look, they don't really look human, but they're humans. It's usually a birth defect. Some of them can be managed, some can't be managed, but usually defects arising in the neural system or the neural tube are usually because of lack of folate supplements. Sometimes it could be due to other issues like genetics. It could be due to issues like yes, majorly genetics. It could be due to issues like radiations. The mother was exposed to radiations. It could be to issues like viruses and infection, like the cytomegalovirus. Those ones can also predispose the child to birth defects. Now, let's move on so that we may be able to save time. Then we'll handle the rest of the questions later. Now, we have natal care. This one I'll go a little bit fast because it's more technical. So natal care refers to the care given during confinement or delivery or during the birth of a child. The objective is to prevent infection. You want to prevent injury to both the mother and the baby. You want to detect and deal with any complications. You want to resuscitate the baby and provide immediate care in case the need arises. Now, what are the activities done during natal care? Again, I've not been very specific because of the nature of the participants. The midwife who is attending to the mother, it can either be the midwife or with a birth attendant and the partner of the woman. So number one, always ensure the mother is comfortable. That's the first thing, the comfort of the mother. The mother is comfortable, the mother is psychologically prepared for birth. If there's somebody she needs to be around, if the hospital policy allows, when a birth attendant, let the birth attendant be there. If the partner can be there, the husband can be there to support her during birth, let the husband be there. Yeah, you prepare the surrounding, you prepare the equipment that are needed. You psychologically and physically prepare the mother. You examine the mother conditions. There's something it's called palpation. You try to do an abdominal palpation to check where the baby is, how far the baby is. You monitor the fetal heart rate. You observe any other vitals, the vital signs of the mother, and you observe what the labor pain and uterine contraction. For nurses and obstetricians who do delivery, there's a graph. It's called a patograph, which is used in doing what? In monitoring labor. Then conducted, being watchful of any problem that may occur and helping the mother in checking pains. In case there's a problem that arises which cannot be handled in that facility, the mother should be referred immediately let's say a case, an example of a cord prolapse. That is the cord, the umbilical cord does what? Imetoka through the birth canal. That is an obstetric emergency. Normal birth cannot continue at that stage. So the mother will need to go for cesarean section. If the facility you are in does not have such provision, the mother should be referred immediately to the nearest higher level facility. Then we give immediate care to the mother and the baby after delivery. The immediate care includes ensuring the mother's uterus is well contracted and firm, ensuring the bladder is empty, ensuring the mother is kept warm, the mother is fed, attend to any needs of the mother, the baby, keeping the baby warm, ensuring the baby does not lose, because young newborns tend to lose a lot of heat, and also giving instructions to the family, to the mother and family members. Remember, this is a time when there's a lot of anxiety, both the family members and also the mother. The mother is confused; she does not know even what is happening. In fact, if it's first-time parents, the partner is confused. I remember one of the time I met a case where it was a university student. So I think she was a first year, and when she came in, she was in active phase of labor. She's not sure of how she's going to give birth. Now she's asking, sasa nitazaje, mtoto atatokea wapi? You say such questions. Of course, here tiajui mtoto atatokea wapi. These are things probably she has been told during antenatal care. But because of the confusion that are setting, the anxiety, mother becomes confused. Now you want to really reassure her and keep on communicating to the mother, keep on communicating to the relatives of the mother on the progress of labor to alleviate anxiety. Very important for those ones who are nurses, again, you maintaining record and reporting of birth to authority. So there is a system in which you that is giving birth notifications, recording, maintaining records on cadices, on the progress of labor and the labor notes. Any other activities which can be done? Are we still there? Somebody raised, mtu alikuwa ameinua mkono, sijui kama ameweka chini. Okay, thank you. Now, postnatal care, like I said, postnatal, now the focus has now shifted from the mother alone to the mother and the baby. Now we have two human beings that we should be looking at. So this is the care given to both the mother and the baby. You want to restore the mother back to pre-pregnancy state. You want to ensure the baby has optimum health, good nutrition. You want to prevent any infection. Now, what are the activities which are done? For the baby, we usually do a lot of clearing of the airway to ensure the baby breathes well and to avoid what is called aspiration. There's something called UPGA scoring. I'll leave this one. This one is technical. You want to maintain the temperature of the baby. That is why we advise, let the mothers come with enough clothing. So after the baby has been born, it is wrapped very well, dried. After drying, if the facility has a radiator or a resuscitator where babies are kept warm, the baby is kept there, dressed, and a valisho kofia, because they lose a lot of heat through the head. A valisho kofia so as to maintain what? To maintain the temperature. You want to do eye care. Eye care for these babies, usually the eyes are wiped. Then we have a drug called TEO, tetracycline eye ointment, and inapakwa kwa macho. Then we have care of the umbilical cord. There's after the umbilical cord has been cut, mother is advised, should be advised on how to take care of the umbilical cord. Does she apply anything ama aiwache hivyo? should the mother tamper with it or not? When she's dressing the baby, where does the cord is wakati anamvalisha diapers? Does she wanafungia hiyo umbilical cord ndani ya diaper ama it should be hanging from outside? So the aim of cord care not to prevent infection, because infections can easily arise from a contaminated umbilical cord. Then you've got skin care. Now I'll go back to where somebody was saying if you have sex during pregnancy, you'll get a dirty baby. The baby where akondani is in fact, there is no temperature, there is no safe place in this world like the mother's womb. Very protected. The amniotic fluid, the placenta. And then now we've got something called vernix caseosa. Vernix caseosa is some substance that usually covers the baby, the body of the baby. Inakaa kama mafuta hivi. So if you go into some villages, when a baby is born, I don't know that is why they say mtoto ni mchafu. No, mtoto si mchafu. That is a natural, it's a natural substance, and it plays a big role in protecting the babies. Number one, it protects the baby's temperature, so the baby does not lose out heat. So when a baby is delivered and is covered in vernix caseosa, it's not advisable to wash the baby or wipe away the vernix caseosa, because this vernix caseosa doesn't harm the baby, it's protective. So the birth of the baby should be delayed. Don't wash the baby immediately after birth. Delay it up to 24 hours later. That is when at least the baby can be sometimes even up to 48 hours. The physical examination is done to both the baby and the mother. So for the baby, you are trying to check. You do a quick physical examination from head to toe, trying to check if there is any birth injury, trying to check if there's any malformation, trying to check if the baby's anus is patent, if the baby can micturate, because they usually micturate within the first 1 hour of birth, the baby has urinated. So you're trying to check if all these things are patent. The next thing, breastfeeding. You encourage the mother to breastfeed as soon as possible, usually within 1 hour of birth. If breastfeeding is delayed, it will be a problem to the baby. Now, what are the postnatal activities done to the mother? Again, just like I've said, after the placenta has been delivered, the mother is given an oxytocin injection to help the uterus contract. The fundus of the uterus is usually palpated. If there is anything that is preventing the uterus from contracting, it is removed, like blood clots or any retained products of conception. They should be removed to encourage the uterus to contract. Remember, if the uterus is not well contracted, the mother may continue bleeding, and that is called postpartum hemorrhage. Remember, we said hemorrhage is one of the leading causes of what? Of maternal death. Next, we need to do inspect the perineum of the mother. Is there any laceration? Is she bleeding from the perineum? Before you do what? Before you give her, not really a napkin, but pad, sanitary pad. Next, the mother is made comfortable by removing Ali Adele, I think. Okay. Thank you. Okay, fine. Let's move on. This is technology. Wow. So, like you are saying, the mother should be made comfortable by removing any soiled linen. You want to ensure the mother is comfortable and warm. She's given something to drink. Usually after a mother has delivered, they are very hungry. they feel cold. They feel cold, and their vital signs. JJ, kindly you can side chat me. Then I check what's happening.
I'm just trying to remove the dick that is in the screen. I'm just trying to remove it.
Oh, JJ is part of us.
Yes, I'm trying to remove the screen, the drawing.
Mercy, you can help me here.
Okay,
Yes, I
let
can
me-
help. You can give me the host. I can help.
Okay, fine. I think Mercy, just leave it. I think I'll handle it. Okay, fine. That's okay. I hope you nini imetoka. Dudu imetoka huko kwenu pia.
Yeah, imetoka.
Thank you. Now we can move on. Oh, Ali, see, kindly please remove this. There's a guy called Ali Adel. You can remove him, so that we go on. So anyhow, let us go on. Now, as I was saying, Mercy, have you been able to get this man called Ali? Can you please confirm?
Oh.
Okay.
Oh my God, is that a dick?
You can also remove JJ because I really don't think he's part of us.
He just left.
I removed him, but it's okay. Let's move on. There's somebody also called Z. I don't know if Z was part of us, but kama he was part of us, nimemtoa by mistake. But let's move on. Now regarding the mother, they have disoriented me, but it's fine. Now, like I was saying earlier, as we wrap it up, we have what is called targeted postnatal care. After the mother has given birth, we have postnatal care, yes, but we also have targeted postnatal care, especially done in community health. That is, it's very important to give regular and frequent visits to postnatal, to the postnatal mother when the delivery is conducted, after delivery is conducted, when the delivery is conducted at home. So a healthcare worker should be able to visit the mother within the first 48 days after birth. If that birth was done at home, visit the mother, try to check how she's doing. Then a second visit is done after 1 to 2 weeks, a third visit after 4 to 6 weeks, a fourth visit after 4 to 6 months. Try go read what happens during this time. What are the objectives of each visit? So, like I've said, this is what is done during those visits, but you can be, if you want, you can be specific on what happens on each particular visit. Now, what is your aim during these visits? You want to ensure that the mother is taking adequate nutritious diet, the mother is having sufficient rest and sleep. Remember, if the mother doesn't have sufficient rest and sleep, it will affect her psychological state, and she may end up into what is called postpartum psychosis or postpartum depression. You want to ensure the mother is keeping herself clean and protects herself from infection. You want to ensure the mother is breastfeeding her baby. This is something that usually is a problem to many first-time mothers. They have a problem, so you want to ensure she's being supported. Then, what is the care to the newborn baby? Just like we said, it's a more of repetition to what I presented earlier. So what is your objective? What do you want to see in the baby? You want to ensure the baby is adequately clothed and kept clean. The baby is being breastfed on demand. The baby is allowed to sleep and rest most of the time and handled only when necessary. Remember, young children use a lot of energy. So to be able to conserve energy, you want this child to be rested at all times, unless when she's being fed. Because akisumbuliwa, he's using a lot of energy, and maybe she's not being fed well, then they become lethargic. You want to ensure that the baby is not being given what? Bottle feeds. Thank God, bottle feeds have now been banned in Kenya. Then we have childcare. This is the last bit. This one I'm just rushing through. Childcare is the care given to children from conception to birth up to the age of 5 years. And what are the activities done during care? Every child must get proper nutrition, and every child must get proper nutrition, which will these guys, to be able to maintain body temperature and rest well. Next is that children fed well for them to obtain optimal nutrition, exclusive breastfeeding for 6 months, and then breastfeeding should be continued up to how many years? If breastfeed children back up, you can type them in the chat box so that the rest can see. During weaning, you want to ensure that the child is weaned off appropriately. If there's any supplementary food that is being given, it should not be beyond the appropriate age and weight measurements. You want to monitor the development of the child. There are things which we call development milestones. So you want to ensure that the child is having achieving the right development milestones at the right age. Come on, Kuketi, the child should sit at the right age. If it's crawling, if it's speech, if it's walking, when should the child make these development milestones? If the child is not achieving these milestones, then the child is said to have a delayed milestone, or the child is failing to thrive. Immunization, we want to ensure the child receives all immunizations according to schedule. In Kenya, we have what is called KP, the Kenya Expanded Program for Immunization. You want to check it out at birth, which vaccines is the baby getting at 6 weeks, at 6 months, at 10 months, at 10 weeks, at 9 months, which vaccine is the child getting at every appropriate age. And in case a child misses out on vaccines, what do you do? How do you approach it? Mtoto alikosa BCG na alikosa polio ya kwanza, na amekuja for the first time in the clinic. How do you approach it? Now, again, remember we said aim of this MCH is also to ensure safety and security of children. Children should be provided with a clean, safe, and comfortable physical environment. The water they drink, the food they eat should be free from toxins. The disease-carrying insects must be controlled, like mosquitoes. Accidents and hazards need to be removed or controlled. That's why some of the hazards chemicals, usually keep away from children. So it's a safety measure to ensure that parents are able to read these and keep those, because remember, children, when they are young, when they hold items, their first reflex is to take them to the mouth. It's when they are still at the oral phase of development. So imagine amepata rat hapo, and then achukua ameze ama weke kwa mdomo. So you want to ensure all these things are out of anything hazardous is out of reach. Then as a mother or a caregiver, you should be able to recognize early ailments and common diseases in children, diarrheal diseases, respiratory infections, especially diarrheal diseases, and acute respiratory infections. These are the common diseases of childhood. Diarrheal diseases and I think up to that, I've come to the
Thank you for the presentation. It was a nice one. We'll have it soon, another one. You can leave at your own pleasure.
I don't know if you could add me back. I'm trying to join.
Okay, let me try. You can just join. Or do I send you a link?
I'm sorry I left. My laptop went off. Allow me use my phone. Unfortunately, now I've missed out on all the questions. But thank you very much. I don't know if there's any question about Jajibu. Luckily enough, but the presentation was complete. Mercy?
I guess you are muted.
Can you hear me?
Try unmuting yourself. I can't hear you even a bit. Okay, thank you everyone for joining. I think so many questions are unanswered and we are past the time. I will send the notes after the class, probably tomorrow in the classrooms. And any question that you might have, you can send it through my inbox directly. Then I will forward it to Mr. Donald for the answers. Then I'll give back the feedback. Thank you, Mr. Donald, for the session. It was a nice one. Okay, I know so many people have been inspired and so many people have learned more about the pregnancy and danger signs during pregnancy and child. Okay, the pregnancy duration, all that. It's a risky stage for a woman, but we have to try it. And by getting the knowledge, we'll now know the risk factors and how to handle it. Thank you so much. We can, okay, in case there's more question, I will be checking in on my inbox. I guess everyone has my number, but let me type in my number on the chat box. Yeah, you can inbox me through that number. I'm the SRHR coordinator. You can inbox me, or even in the other previous sessions, you can inbox me for the for questions, and then I will send back the answers after the speakers answer them. Thank you so much. Everyone have a good night. You are free to leave. Yeah, thank you.